Our next speaker has treated sleep apnea and snoring in Bellevue, Washington, one of the most beautiful places in the world, I might add.
Right.
All right, since 1998, he's a consultant to the ADA for sleep-related breathing disorders, has trained at UCLA's mini residency in sleep, and is a diplomat of the American Board of Dental Sleep Medicine. He lectures internationally, directs sleep education at Airway Technologies and the Pankey Institute, and is a guest lecturer at Spear Education and the Louisiana State Dental School, in addition to advising several other sleep-related manufacturers. In 2014, he helped found Dental Sleep Practice magazine and currently serves as chief dental editor. In 2019, he helped co-author the handbook, A Clinician's Handbook for Dental Sleep Medicine. All right, please welcome Dr. Steve Carstensen.
It's a joy to follow Ben Moralia. It's also challenging to follow Ben Moralia because he really helps us think about lots of things in a different way. Imagine, as I'm sitting there listening to the stories about those families, think about not just the dental things you heard, not just the medical things you heard, but think about the quality of life of those families. And as we go forward with this, my task today is to talk to you about what Ben was talking to you about. He mentioned nasal breathing many times. So I'm going to give you some fundamentals. Why nasal breathing is so important. We have to get all of our people, kids, adults, to breathe through their noses all the time. And it says dentist up there, but I know we have more than dentists in the room. And but it's for all of us to think about that. So welcome to you. This is my first time speaking at this meeting. I'm happy to say that so far the microphone's been working just fine. So thank you, AV team. And welcome to all the people online as well. Oh, good, they're getting the lights down. So yeah, there's my conflicts. I'm supposed to read this to you. I do not have any financial interest in a product in my talk or with any of the companies offering grant monies for this continuing education and dental medical education program. I'm connected with lots of industry out there. I've spoken. I've been an educator for a long time. I always talk about nose breathing or growth and development or dental sleep medicine for whatever manufacturer wants to pay me to talk about that, because my role is to get dental professionals and medical professionals educated about the importance of nasal breathing and about growth and development, about treating sleep apnea. So there's products in my program today. I don't make any money on any product unless you buy that book, and eventually if you buy that book I get $3.80. So please buy lots of them. But nothing else that you see as a name brand has anything to do with any financial benefit to me at all. It's just products I may like. So the whole key, if you can get every one of your patients, when they walk in the door, just observe what they do. You heard Ben say that. He watches his patients breathe. Look at all of your patients. See what happens. Look around in the airport, in your family circles, and see if anybody's breathing through their mouth. Nobody should breathe through their mouth unless they have a transient nasal blockage. Because we get rhinoviruses, we get colds. And thankfully, we get two ways to breathe, because if we were able to plug our noses with a rhinovirus and couldn't breathe, well, that would be a problem. So we have two ways, but that should not be our habits. Dr. Christian Guilleminault wrote a landmark paper a number of years ago, and he put this challenge to us. Nasal breathing 24/7 is the only finish line that's important. So nasal breathing 24/7, most importantly at night. Most importantly at night, because the physiology of the nose changes, the physiology of the body. The reactivity of the whole body's health changes while we sleep. We can control what we do in the daytime. We can't control near as much at nighttime. And so what we have to do is create good daily habits that carry through into nighttime breathing. So we'll talk about that. Because as much as we can see protruding teeth, as much as we can look at profiles, as much as we can see an arch form that doesn't match up with good breathing habits, what we have to look at is the nose. When you ask people, what's the first thing you notice about a face? You ask them, they'll tell you. It's the smile. You ask them, they'll tell you it's their eyes. You do a survey with science, people notice noses. It's not as conscious for that because it's plain what we have to do. In dental schools and dental hygiene schools, we're trained to look at this subject. Oral cavity. Physicians are trained to ignore this. Now they're trained to look at the soft tissues. They can check for signs of cancer. In some of the physician notes I get from my diagnosing doctors for sleep apnea that I treat, it says things about crowded arches or narrow oral pharynx, but they're not really trained to look at this. You ask any physician about details of the oral cavity, and they'll defer to us. That's good. We're specialists in this area. Cardiologists don't talk about kidney disease. Orthopedists don't talk about ear, nose, and throat. So physicians don't talk about oral cavity health. That's our job. But the definition of dentistry, is, according to the American Dental Association, says that we're in charge of all these things about the oral cavity, the TMD, all those things, but also adjacent and associated structures. So like you've heard so far this morning, what's adjacent and associated to the oral cavity? The nose, the back of the throat, the structure of this. Physicians who diagnose sleep-related breathing disorders, who think about closing down of the airway during the nighttime, think about disturbances to the respiratory cycles, they don't think about the structure of it. I get referrals in my practice to make an oral appliance to help somebody breathe at nighttime because they can't tolerate a CPAP, for example. Great. I love doing those because people breathe better with them. But what I look at is the structure. So when I see somebody, I see most of my patients with a structural issue, we always have that conversation. We have that conversation about going and changing the structure, to ignoring the teeth, like Dr. Moralia says, to look at the bony structure. What's causing these problems? And we'll talk more about that in just a second. So what does dental school and dental hygiene school teach us about noses? Well, there's the extent of it right there. I did the diagnosis, I did the section of a nose when I was my first few months of dental school. Did I have any context for that? No. Did I want to get out of that class with knowledge enough of where that pin was that I could pass the test? That's what my goal was. Did I think about, was I instructed in the function of how a nose works? It's a hole that you breathe through. That's how much instruction I had. You know, but there's tissues up there, there's responses up there, and there's a lot more. There's a lot more that we are now beginning to get some excellent literature about. There's going to be 4 books. These 2 are excellent books here. John Walker is an orthodontist. Dr. Peter Catalano is an ENT doctor. Both of those doctors are good friends of airway health, of nasal breathing, of growth and development. Dr. Howard Stupak is an ENT surgeon in New York City. Look at the title of his book, Rethinking Nose Jobs and Facial Surgery. Why would a dentist pick up a book that says Rethinking Rhinoplasty and Facial Surgery? Because the first half of his book is about growth and development of the upper jaw related to nasal function. It's fascinating. He's a great guy. He should have titled this completely differently. I'm a book author, so I know what editors do to book titles, but I think that's poorly labeled. It's an excellent book if you're interested in growth and development of the upper jaw. And you can see some pictures out of that coming up. Everybody that breathes should read James Nestor's book, Breath. It's an incredible book. James Nestor's a medical journalist. He's put a lot of work into this. He experimented on himself to see what it's like. It's a wonderful read. It's a good story, and you learn lots of cool things. Patrick McCowan is I don't know what his training is, other than he's a breathing coach, but he's the global leader in breathing. He's written several books. The most accessible book probably is called Oxygen Advantage. This book is an encyclopedia. I actually just finished it on a plane last night. It's, 500 pages. It goes into great detail, lots of science. So if you're really into how you can affect physiology simply by coaching breathing or breathing yourself better, then read The Breathing Cure. If you're interested in other things, get Oxygen Advantage, same author. So when do dental teams think about nose breathing, think about these things? Well, there could be an appointment on a calendar where we have schedules to fill, and somebody calls and says, I can't make my dental appointment. And why can't you? Because I have a terrible cold. So then we blame the nose. We say, oh gosh, they have a cold. They can't keep their mouth open for my hygiene appointment, for my restorative appointment. So now we have a hole in our schedule. That's when we think about noses as a dental team. We hate them because they get in the way. They mess with our scheduling. We also think about them perhaps when we're doing restorative dentistry. We put a rubber dam on. In the Seattle area, anyway, we used rubber dams a lot. And so we put this on, and the patient says, I can't have a rubber dam. Why not? Because I can't breathe. If I can't breathe, I can't be here. So why can't you breathe? Well, I can't breathe I have to breathe through my mouth. In my restorative days, I was a restorative dentist for 32 years. I would do things like cut holes in the rubber dam so they could breathe around that. That's a workable solution. But I never really thought about coaching the patient into saying, well, why is nose breathing such a problem for you? Maybe we should address that, because I didn't know to look. I had that extensive nasal breathing function training in dental school. You know, their nose couldn't work, so okay, let's cut a hole in the rubber dam. That was my solution. It worked for my restorative practice. I got to do the work I needed, but I never thought, could I have improved this patient's health more? Now, if I was still doing this and somebody said I can't breathe through my mouth, I probably would put off any acute dental troubles until we solve the nasal breathing problem. Because what's the bigger problem? It's the nasal breathing problem. So, how do you learn about these things? You learn about them on the medical history form. I'll bet that none of you, few of you, will have any questions about nasal breathing on a medical history form. I know there's people in here that have learned about this. But most of you have questions about colds, about high blood pressure, about diabetes, about other diseases that are connected with poor breathing. Sleep apnea, the worst of the disease, obstructive sleep apnea. Even mild forms of that are connected with bad nasal breathing. You have those questions, so you can keep going. So what happens when we breathe through the nose? Why is it important for us to breathe through the nose? As we inspire through that portion of our anatomy, a lot more happens than just gases passing through this territory and getting into the lungs. Did you know that, I took a hike in Alaska. I was doing a lecture in Fairbanks, Alaska in January. And I wanted to go to Fairbanks, Alaska in January because one of my friends had lived there, and she said, Steve, it's amazing when it's 40 below. I gotta tell you, I gotta tell you, this is probably not appropriate for this. I should. She said, Steve, she said, you'll never know what it's like until you go to the balcony and pee off the balcony at 40 below. It's amazing. Oh, sorry, online folks. Anyway, so I was out for a hike. It wasn't 40 below, it was 0. It was still 0. Okay, so I was out for a hike. I was breathing in 0-degree air. When it's 0 degrees and it's been snowing, that air is very dry. 0-degree air, nearly 0% humidity. By the time that air reached the top of my tongue and my oral pharynx, there was body temperature, it was 100% humidified, and it had been filtered by the nares, the little hairs in my nose, and not sterilized, but it had been, all the bacteria and viruses had been knocked down by nitric oxide produced in my sinuses. That much distance, a couple centimeters, 100% humidity, fully warmed. That's one of the magics of the nose. But if all we did was breathe in dehumidified air, humidified it to 100%, and then we breathed it back out, and we let the body get rid of all of that water and all that heat, what do you think would happen over time? We would dry out, and we would cool down. So when I breathed out that 100% body temperature air, by the time it exited my nose later on, It was down to about 30% humidified, but still body temperature. Because I can generate heat in my body. I can't generate water. So the nose air conditions the air coming in, and it air conditions the air going out to preserve our physiology. It's magic. How does that happen in 2 or 3 centimeters? That tissue inside there is amazingly capable. So what do some of the ear, nose, and throat surgeons do when you send somebody to them or a patient wanders in saying, I can't breathe through my nose? Some of the surgeons, like some of the orthodontists, have a short-sighted view of what their role is. And they go in and take out pieces. They take out septums that move over to the side. They take out turbinates that are made to warm and humidify the air. Some surgeons. Other surgeons are doing more advanced things, much like some orthodontists are no longer thinking of only of the teeth. Not the poor victims on the screen earlier, but we have good orthodontists available to us these days as well. If you breathe through your mouth, none of those things happen. If you breathe through your mouth, that 0-degree air that I was hiking at in Fairbanks was probably half body temperature, maybe, at most, by the time it reached the back of my oropharynx. It was dry as can be, so my mouth would dry out instantly, and there was no filtration going on whatsoever. If I was 3 or 4 or 5 years old, breathing in that dirty air, and I have very active adenoids and tonsils, those tonsils and adenoids might react to those contaminants and overgrow. They won't do it when I'm an adult, but that's what happens. And do you think it's easier to breathe through your nose or your mouth? Sometimes it's easier. It feels easier to breathe through your mouth. But when we measure it, it's easier to breathe through your nose. There's less resistance. And the reason why is because the back of the throat, the oropharynx and the hypopharynx, just below the tongue, those areas get more resistive when the mouth is open, the jaw drops, the tongue sits down on the floor of the mouth so we can breathe. The base of the tongue limits what we can breathe. But you can't feel that. You feel the flow. And so it feels easier to breathe through your nose, but there's actually more resistance to breathe through your mouth than your nose. And then here's the magic molecules, the magic compound, nitric oxide. Nitric oxide does amazing things in our bodies. It's produced by nearly every cell of our body, lots of places. It's produced in the most quantities in our sinuses. So as we produce this in our sinuses, we breathe it in, and it's pulled from our sinus tissues into the combination of airs that would end up in our lungs. What happens in our lungs with nitric oxide is the blood vessels expand. The blood vessels become better exchangers of gas. So we have a better use of oxygen, a better response of CO2 to get back into the expired air. So nitric oxide is absolutely required for respiration. It has something to do with the surfactant that goes in the lungs as well, the surfactant that makes the tissues expandable in our lungs and makes them work. That all comes from our sinuses. In the respiratory tract, there's not another place where nitric oxide is produced. It's produced, again, all over our bodies, but it's not produced in the respiratory tract other than our sinuses. So if we breathe through the mouth, we don't get very much of that. They've done some studies, some recent studies because of the pandemic, and it turns out that nitric oxide has a very strong antiviral effect. They've done some very exacting studies on SARS viruses, not necessarily yet on COVID. So, if you breathe just through your nose, gently and quietly, you'll get about 180 nanoliters per minute of nitric oxide. Great. But if you hum while you breathe in, look what happens. It goes up by a huge amount. Nobody knows why. I'm curious why they did the study. But they found a lot of it that way. Who thought of that? Let's make them hum, okay? How much do you get when your mouth breathes? Less than nasal breathing. So what you can do is you can have your patients who are concerned about viruses in their nose, concerned about respiratory breathing, and we're going to have some exercise in a little bit. You can have them hum while they breathe inwards. Now, they might want to do this in private because if they're in the bus humming while they're breathing around other people or at work or on Zoom, might be a problem. But normally what you want to do is have them do their exercises in private. So breathing slowly through their nose and humming, we're going to add a lot of positives to their respiratory cycles. So why else is this important? Nitric oxide is critical. Warming and heating is wonderful. But are there other reasons to breathe through our noses? There's plenty of them. There's a fascinating connection between the nose and the brain. Now, we understand cranial nerve 1. Cranial nerve 1 is the way we understand our environment by what it smells like. There are odorants in the air, Axe body spray apparently, and it attaches to these specialized nerve fibers and goes with only one synapse to the cortical regions of our brains. Other animals understand their environment by what it smells like. We know that's from our pets. Humans don't do that so much, but we do have a little bit left of the evolutionary cycles, and we see only one synapse. So we get information to our cortical part of our brain, our thinking part of our brain, very quickly from our nose. Great. What else happens? Signals go to other parts of the brain from those specialized cells. So there are mechanoreceptors also in cranial nerve 1. When I learned cranial nerve 1 in dental school, it was all about smell. When I learned how to do a cranial nerve exam as part of my training, they said, well, we don't really test for cranial nerve 1 except can you smell or can't you smell, ammonia or something. Didn't talk about this. This is recent research. There's mechanoreceptors in some of the cilia inside of your nose. Cilia is there to move the mucus along. It's a critical function of the nose. Some of the cilia are mechanical, which means they send a signal when they move. So when you breathe in and out, those little cilia fibers are registering that you're breathing in and out and sending nerve signals to parts of your brain. The limbic system part of your brain. Now, what's the limbic system? Limbic system is the center of our brain. It controls pathways of nerve impulses from the lower parts of our brain, from the cranial nerves, from the cortex down. It's the gateway to much of what our brain and human function does. Different parts of the limbic system have different roles. We have the amygdala that controls memory and emotions. Hypothalamus controls much of our body physiology. There's whole days worth of lectures, books written about the limbic system. But without the limbic system, our bodies don't function. So there are signals that go to the limbic system. So nasal breathing, turns out, it sends a rhythmic oscillation to that limbic system. And if you stop nasal breathing, the signal stops. We don't understand the full implications of this. But there was an unfortunate individual in Chicago whose limbic system was disconnected from some epilepsy. So they were doing an experiment with him because he had nothing else to do, and they drilled holes in his skull, put wires into his limbic system to tell kind of what's going on with this poor guy. Well, while the surgeons were doing that, the scientists in Chicago said, wait a minute, we have this opportunity. So they got his consent, and they started measuring electrical signals to the limbic system with his mouth open breathing or with his nasal breathing. It wasn't part of his treatment, but they just took advantage of the fact that these wires were there, and they're not going to go anywhere else in anybody else's brain on a random basis. You can't even get dental students to agree to that. And they measured these things, and there was a very clear difference between the signals going to the limbic system between mouth breathing and nasal breathing. We don't know what that means, but it means something, otherwise it wouldn't be there. So what it underscores is the value of nasal breathing. And what the scientists concluded was that these oscillations are a clock. It helps the limbic system keep track of the rhythm of our physiology, of our circadian rhythm, of our normal physiologic ups and downs that happen through the day and nighttime. So there's something associated with that. What does that mean? nasal breathing 24/7 is our only valid finish line, just what Dr. Guilleminault told us. So it's a perennial rhythm. It happens throughout life that way. It stabilizes our function as far as they can tell. Now, these are waveforms. The waveforms on the upper right of the screen there are from a mouse, because they can do more experiments on mouse brains. And they can, that little snippet doesn't mean anything to you, but what it is intended to illustrate is that scientists look at different parts of the brain. They look at the electrical signals, and they correlate signals from one part to another part, and then they look at the physiology that's going on and the neurophysiology that's going on, and they wonder what's happening. What questions does that prompt? What does it line up with in terms of things that they can observe? And when they see these correlations, they can start to put together the neurobiology, the scientific part, with the clinical part. What are people complaining of? What can we observe in a human? What can we observe in lab animals as well? But what can we observe in humans that might be correlated with this? That's how we're going to get this done. That's how we establish a medical type of direction, clinical practice. So it's more than what the patients tell us about. It's what we can see from the physiology. So scientists have said, well, obstructive sleep apnea, there's a disease that people can observe. It was first diagnosed by observation in hospitals. At that time, overweight old men were dying because they stopped breathing. Physicians wondered what was going on, so they started looking into this, and they decided it was an obstructive part of the oropharynx, and that's what the problem was. Well, that's part of the problem, but that's not really what the problem is. And other scientists have looked in here, and they said, well, okay, 100% of people with obstructive sleep apnea, the end point of a long series of poor breathing patterns, 100% of them have an anatomic problem. 100% of them did not see bemorrhalia when they should have. 100% of them have something that restricts the airflow. But there's other things going on. There's things called ineffective airway dilator muscles. We have a lot of muscles surrounding our airway. While we're breathing right now, you're breathing negative pressure into your chest to bring air in. Right now, your genioglossus muscle is keeping your tongue from being sucked into that oropharynx and closing down your airway. Whether it be a coffee stirrer, straw, or a garden hose, that muscle's working. People with obstructive sleep apnea have less function of those muscles while they sleep. Two other things are happening. Some people wake up very easily. We know them as light sleepers. As soon as the oxygen-CO2 balance becomes out of whack in their blood system, their body responds and wakes them up to get that back into balance. Other people can sleep through large changes in their oxygen-CO2 balance without waking up. But some people are very twitchy about that. And when they do get twitchy about that and they respond to that CO2 going too high or the oxygen going too low, then they respond in varying ways. Some people gasp and choke and breathe deeply and hard for a little while, and they overbreathe, get rid of too much CO2, which lowers their signals for breathing, and they end up stopping breathing again. If you've ever heard of central sleep apnea, that's when the brain does not send a signal to the diaphragm to breathe. That's where that happens. Too much CO2 is gone, and so it ends up with a low breathing effort. So look at this child here. Watch his chest pattern while he's breathing. Now imagine, this is a before bemorrhalia patient. Imagine, can anybody look at that breathing pattern and think that that child is going to grow up with their maximum potential? Not a chance. You don't have to be any kind of a diagnostician to think there's something wrong here. Believe me, the parents think something's wrong here. The problem is the parents go to the medical community and they say something's wrong here, and the physicians say, oh, no, I don't see anything wrong. The orthodontists say, oh, there's not enough room for teeth. Let's do something about this. So currently, we don't have enough knowledge base across medicine and dentistry to recognize every child that has this kind of a problem. But certainly these things might train the brain to have these over responses to oxygen CO2 balances that end up with this child being a poor sleeper when they're adults. Because this is a 4D problem. We have 3 dimensions of space. We have the growth and development of the airway, as you heard earlier. But we have this over time. And bodies respond over time. So while we're young and the bone is growing, if we breathe poorly through our mouths, then we're going to have an underdevelopment of the bony structures. As you go a little bit further in life and growth is finished, now all the disruptions go to the limbic system. And young people, young adults, complain of headaches and TMD and IBS and fibromyalgia, chronic inflammatory diseases. If those carry on for a long time, we have these chronic non-infective diseases of heart disease and kidney disease and other things. Because as health declines over time because of these chronic non-infectious diseases, physicians look at that and they don't realize where it came from. They have to treat the symptoms, the things that they see. You go to the cardiologist and he treats the high blood pressure. You go to the kidney doctor, they treat the diabetes. But they don't think about where it came from. So why, if we have reduced airflow, why is that? What structures get in the way? All of these things get in the way. And so if we go to a surgeon and they look in there and go, wow, that septum and those turbinates, they couldn't possibly let you breathe well enough. So the surgeon says, let's get those out of there. But how do they get that way? So they get that way from the things you heard about earlier, the dystrophy of the craniofacial development. Our friend Kevin Boyd calls it the craniofacial respiratory complex. Good name, hard to say, craniofacial respiratory complex, because all of these things end up with poor nasal breathing. How can you test for that? Well, it's pretty easy. One thing you can do is you can have a mirror in your refrigerator and just have them breathe in, put the mirror under their nose, and breathe out. See what it looks like. See what fogs. Is it the same on both sides? Does it extend a long way out on the mirror or not at all? Those kind of things you can test. So I was saying this, and somebody else said, well, just have them use their phone. They can pick their phone under there, and so you don't have to have a cold mirror that you have to clean. Just have them breathe onto their phone. I thought, well, that's kind of gross, but it does the same. It actually works, so you can do that. But wait a minute. Don't these tissues get bigger just because of allergies? Isn't that what we've been told? Aren't they bigger because the nose tissues have responded all these years to allergies in the environment? Part of it. But what else could be done? And how do we treat these? We treat these with medications. We treat these with rinses. Well, maybe not. Maybe what we do is we treat them by not letting them do this. Not letting them be the walking into Ben Moralia's office type of appearance. Not chronic negative pressure is what can cause this. This is what Dr. Stupak teaches us in the first half of his book about nasal surgery. He says, wait a minute, how did that happen? And he put up some experiments, he made some cool little discoveries. But when you breathe through your nose, you have negative pressure when you're breathing in, you have positive pressure breathing out. So the pressure goes low, it goes high, low and high, back and forth, breathing through your nose. If you breathe through your mouth, the only pressure you have in your nose is negative pressure. Because as you open your mouth and breathe in, a little bit of that negative pressure extends into the nasal cavity. There's no positive pressure when you breathe out because it all flows out through the most convenient pathway out through the mouth. So there's no positive pressure going in, so only negative pressure in the nose. And if you do that over days, months, weeks, and decades, the tissues break down. So what happens when you have that is you have patients who are not responsive to therapy because what happens is these chronic negative pressures actually disrupt the tissue health. It's not just negative like ballooning up a turbinate, but when you do the studies, you'll see that actually the tissue layers were disrupted by this chronic negative pressure. So you can't reduce that necessarily by just rinsing. We want to reduce it by not letting it happen in the first place. We have to get to nasal breathing. Now we can do some things, some medications, some treatments. There's lasers we can use. There's other ways we can use to affect those tissues. But what we really want to do is be preventive about that. If you've ever looked in the back of the mouth and you see the uvula there, it's all swollen and red. What could be the cause of a swollen red uvula? It's going to be mouth breathing, but why would it swell up? It's because it's being beat up in a negative pressure environment. Then the mucosa's changed. Nightlaze is out here. Nightlaze is an excellent way to control that tissue change because it has predictable effects on the connective tissue layers underneath the mucosa. That's how it works. There are other ways to make that work as well. So when you see this back there, don't ignore that and think, well, something must be wrong. Well, how about them teeth? You know, we got to think about what else we're looking at. So what is the best age to breathe well? Is it ever okay to breathe poorly? You saw plenty of evidence this morning about why we should start at 3 or 4 to make sure that these kids don't end up to be 9 or 10 or 12 or 16 or 19 with those kind of problems. So it's never okay. And so when should we start paying attention? As soon as they start breathing. That's when we start. So how do we diagnose an airway resistance problem? Well, one way you can do it is if somebody comes in and they say, well, I can't breathe through my nose. And why is that? Well, I have allergies to everything. Well, one way to test that is to give them what is traditionally used is mild steroids. Flonase, fluconazole, is fluticasone, there we go, is a common thing to use. And why do ENT doctors use that, and primary care doctors use that, and dentists use that? Is because it works, and we can tell if they're allergic to something in their environment if we take away the response to the allergy and they get better. Now, there are other ways to decrease responses to allergies, but this one is a well-proven one. We can also start changing their nasal environment. We can have them rinsing. We can decrease the resistance to breathing with nasal dilators, breathe right strips, nasal cones, lots of ways to do that too. So we can decrease that negative pressure, and certainly we can start to have them be better at breathing through their mouth. ENT doctors use a nose score. It's a subjective set of scales here, 5 questions there and a scale across there. And what we do is we just look and see, well, what's your nose performance like? How do you answer these questions on a 0 to 5 scale? And then the number's not big enough, so they multiply it times 5, and we end up with a score. And if they have a greater than 30 score, they probably are too late to treat it with simple tissue revision by rinsing strategies. We might have to go in and do surgery according to the ENT surgeons, but what if we do it something differently? What if we train them to be better mouth breathers? Can we change that tissue? And it turns out we can. So nose score is a pretty easy way to get people to identify themselves as being poor nasal functioners, along with how they subjectively feel about this, so we can start the conversation. How else can you diagnose it? Observing them. Do these people breathe through their mouth? They shouldn't be, 24/7, remember? If you look in their mouth and you see these bright red gums across the front teeth, in my dental school training, I was told that these, in most of the case, children were somehow not controlling their plaque on their front teeth. They were doing a good job of brushing their back teeth, apparently, but they somehow couldn't brush their front teeth. So I had these ineffective conversations with my patients because I didn't recognize that this is mouth breathing. And that's all it is, mouth breathing. Changing microbiome along those front teeth causing gingivitis, not because of plaque control, but because of mouth breathing and dryness to the tissue. So we got to change that. So here's a simple test. Just have any of your patients hold their lips together and time them for 2 minutes. And if they cannot breathe through their nose for 2 minutes, they need to embark on a whole nother pathway before you're going to be able to make them as healthy as possible. Just 2 minutes. Seems simple. You will find a lot of people who struggle with that, who feel what Patrick McCowan calls air hunger. So, here's something else. Now, okay, this is for you. We're going to all do this. You've been sitting for a while now. It's time to stand up. Everybody stand up. Online, if you're at home, stand up. All right, the BOLT score, which is the basic body oxygen level test. What a BOLT score is you breathe, I'm going to describe it for you, then I'm going to have you do it. BOLT score is you breathe in and out a few times through your nose. Then you breathe gently out through your nose, hold your nose, and wait for the first physical sign of air hunger, which means your body's trying to breathe, sending you the signal that you've got to breathe. And you time that. Now, I'm going to be talking, so I'm not going to time myself, and you can time yourself if you'd like, but that's the exercise. So you can go home and do this on your own. So everybody just take a couple breaths through their nose. I have to stay here for the camera. And now breathe in through your nose and out through your nose, and hold your nose. You have to hold your nose. You can't just pretend to hold your nose. And then count in your head or use your timer until you feel that first sign of, I have to breathe. Some of you are doing very well at this. You can shake it out a little bit and sit down if you like. So what's our target here? Our target here is if you were less than 25 seconds, your body was over-responding to the buildup of CO2 in your blood system. If you were more than 40 seconds, you have trained your body very well to be a balanced response to excess CO2 in your system. The people with high loop gain, which is the over-response part of breathing problems, or low arousal threshold, the people that wake up faster when they have their body's detected imbalance in oxygen and CO2. If you have obstructive sleep apnea and you have one of those two endotypes, your BOLT score might be under 10. And if you're under 10, your body is very twitchy in response to any breathing problems. Lots of people with mouth breathing have a low BOLT score. If you can get over 25, 30, 35 seconds before you feel that response of your body that says, I got to start breathing, you're in a pretty healthy zone. If you want to increase that, there's lots of exercises to increase that. Patrick McCowan and Oxygen Advantage is where this comes from. And so you can study that and increase your BOLT score. That's the first step in making your body healthier breather. The first step in changing how your body responds to breathing while you sleep. The first step in making sure that your nose breathing is not only present, so you are breathing with your mouth closed, but also effective that way. So we can change our central nervous system's response to our blood oxygen levels. This is not taught in sleep medicine fellowships. If you have an obstructive sleep apnea diagnosis by a sleep doctor, they have no concept for changing those endotypes. They don't know that we can get people to breathe better just by breathing better. So they want to do mechanics. It's much like, it's exactly the same as all those unfortunate children that had been given 10 or 12 diagnoses and all these medications to fix their problem instead of fixing their problem. So, what are some other things we have to pay attention to? Allergies, of course. There's lots of allergies in our environments these days. My brother moved to Phoenix in 1990 because his wife was allergic to nearly everything that they were living near in Maryland. So they moved to Phoenix, to the desert, where it's dry and there's fewer plants, so that she could have a healthier life. Well, guess what? Lots of other people moved to Phoenix, and they want to carry their life with them. So they overwater their environment and they grow things that don't belong in the Phoenix Valley. So now Phoenix is just as bad about allergies as Maryland ever was. So humans behave badly sometimes. But there are true allergens in our world. People are allergic to stuff. It's real. So we have to help them get to a clean environment if we're going to get them to breathe 24/7 through their nose. So we do clean environment checks. We ask them about their bedroom environment because nose physiology changes while you sleep. So is it a clean environment? Do they have animals that sleep on the bed with them? Do they have carpet? Do they have a filter system that works? Do they have other ways to make sure that the air they're breathing doesn't trigger the body response? We're happy about allergy response. That's part of our body's protection, but we don't want to challenge it as much any more than we have to. Then we recognize that if the structural problems are not accurate, we send them to somebody who can fix that. If you're anywhere near Ben's office, you send the kids to Ben, and he does things like that to get the structure better. There's other things. That's a representative. If they do have a medical problem, we need medical doctors to work with us because we don't have control over all of that. So some otolaryngologists are wonderful partners for our patients. Not all of them. I have a group, I'm fortunate in my area. Not only do I have excellent orthodontists, but I also have excellent ENT doctors. But I also have orthodontists and ENT doctors who don't understand these things, and so I have to selectively make sure my patients see the right doctors. What does that mean? That means you have to do some interviews. You have to get out and talk to people. You have to understand what their philosophy is. What do they think is important about how to work together with you, the airway aware dental office or medical office or coaching office or whatever is represented in this room. If we're thinking about how we're going to get people to breathe together better 24/7, we can't do it alone. Nobody here has training to treat every problem of breathing. We always have to have more than one person on the team. So you have to find those team members in your areas. Or you can use guidance appliances. MyoBrace is here. You can go talk to them about this. This is exactly what they do. But there are many different kinds of guidance appliances out there, lots of them. And so you can go find somebody who knows how to do that or get trained yourself in how to do that. So Ben's not an orthodontist, but you saw some gorgeous orthodontic endpoints. But what you really saw, didn't you, was structural endpoints. The teeth lined up. What did he say over and over again? The structure's there. So now maybe I'll do some clear aligners. Maybe they don't need anything. Wouldn't it be great that these teenagers landing in middle school have a little bit of crooked teeth that can be aligned with a few clear aligners, but they breathe great? In 1972 and 3, when I achieved the ages where my parents could afford orthodontics, I had the before faces there. I went and they did the only thing they could possibly do at the time. The only thing they knew. Years later, I'm doing a lecture for a bunch of dentists, and a guy came up at the end and said, "Steve, I want to apologize to you." And I said, "Apologize? What for?" He said, "I was your dentist in high school. I sent you to the orthodontist to have those 4 teeth taken out, and headgear, and pull back, and all those things." I said, "Well, thank you for my mild sleep apnea and my snoring that I treat every night with an oral appliance." But you can help people when they're growing with guidance appliances. You can help people when they're adults who aren't going to grow until you force them to, and there's ways to do that. You can help them perceive what it's like with nasal breathing instruments. One of them's on the picture. It's called a MyTap, and it's a heat-molded device. You put it over the teeth. You can use it to advance the jaw, but you don't have to. But the magic of it is what is hard to see on that picture, which is a little silicone shield. And it goes over this little post and under the lips, and that makes them an obligate nasal breather. So that's one way you can do it. If they have obstructive sleep apnea, and you want to help them with that, you can make them one of these, bring their jaw forward to help the oral pharynx, but you mostly are making sure they breathe through their nose. It's very valuable way to get them into treatment for a low cost and immediate therapy. Lots of ways to make these things work, just like we can use guidance appliances of many kinds to achieve results like what Dr. Moralia showed, what these pictures show up here. And absolutely myofunctional therapy. How many myofunctional therapists do we have in the audience? There's an empty chair there with one. There's a few others. There's not enough. There's not enough, because every dental meeting, every meeting about how the dental profession can help our patients should include myofunctional therapists, because you're critically valuable to what we do. And in-person myofunctional therapy is fantastic. It's the best, eye to eye, demonstration to demonstration. But there's not enough myofunctional therapists. So there are plenty of myofunctional therapists that can do it online. Online is second best, but it's way better than zero. And so find a myofunctional therapist in your community, find a myofunctional therapist online. And this one happens to be Sarah, but she does a lot, all of her stuff is online, but she does a very good job of myofunctional therapy. And we can use some interventions like sprays that aren't medications. I mentioned fluticasone earlier, but you can also use just saline. Saline with xylitol. What does xylitol do? Xylitol in the mouth changes the microbiome, makes the bacteria less sticky. So we can use it in dentistry to prevent caries, decrease the propensity of people to have sticky biofilm that causes caries. In the nose, we use it for the similar purpose. Changes the microbiome, makes the mucus easier to flush out. And when that happens, it's easier to breathe through your nose. Spry, that particular one there, happens to have some grapefruit seed extract as part of its formula, which also helps the microbiome in the nose. And it has xylitol, which decreases bacteria and viruses. So it's good all the way around. You can do a spray, you can do a rinse, there's gels, there's all kinds of things you can use. And there's more than just, well, these two companies are two excellent companies, but there's others. And then there's lip taping. Lip taping is somewhat controversial in my area, but lip taping can take a couple of forms. The best ones, I think, look like this. They have little stretchy bits. It's like an elastic bandage. And so what it does is it leaves the lips able to be opened. Lots of your patients, you will talk to them about, well, let's keep your lips together with tape. You mean tape my mouth shut? I'm not doing that, because what if I have to throw up? That's what they all say. How many people in this room threw up last night? Sir, you are in New Orleans. You might have overindulged. But that's what they say. I can't tape my lip together because I might throw up. And then what am I going to do? Well, so what you can disabuse them of that fear, but what you can also do is use a tape like this. So one of the lip tapes is real popular is 3M's micropore paper tape. It's excellent. It comes in 1 inch widths. It's real cheap. This is not as cheap, but it's not expensive either. And so these mild tapes like this, and there's a couple different varieties of this, are stretchy. You put them over the lips, and it trains the lips to stay together, trains nasal breathing. So it's an excellent short or long-term adjunct, so people can feel what it's like to nasal breathe. You can measure this now, too. There's only one machine, I think, that I know about, but you can actually get objective data about nasal function with a rhinomanometry. It's a flow meter. So you can put, if you want to prove to a patient, and I live near Microsoft and Google and all those, so I have tons of engineers in my practice. And they say, well, how do I know? I said, well, blow on this mirror. Well, they don't like that idea. So I said, what about a rhinomanometer? I can measure their nasal function before and after treatment. For some people, that's important. For some people, it's important for them to see visually what's going on. And so the mirror works, the phone works, the rhinomanometer works to help people understand and own their problem. The 2-minute breathing test, the Bolt score, all of those are communication tools for us as we gather data, for our patients as they gather ownership of their issues. Our friend Barry Raphael, excellent. Now he's an orthodontist. He's a real orthodontist who changed his practice, what, Ben, 15 years ago, 20 years ago, something like that? 20 years ago, he was a traditional orthodontist. He was trained as a traditional orthodontist. He did all the bad orthodontic things. And then he realized he was doing bad things to people. And so he switched. Now he doesn't take out teeth. He does functional orthodontics. He makes it easy for them to breathe. And then we have to train them to breathe easy. So it's not just a matter of structure. It's a matter of structure and training. That's where Patrick McCowan and the Oxygen Advantage and the breathing cure comes in. That's where the myofunctional therapist comes in. Because if you have a child or an adult who has spent years or decades breathing badly with the tongue in the wrong place, it's not enough to release the tongue. It's not enough to change the structure and leave those habits alone. I'm not a very good golfer, but if you took away my 12, 15, 20, whatever, how old, Mizunos and gave me a brand new set of Taylors, I would still have to change my golf swing to take full advantage of those shiny new clubs. So if we give patients a shiny new arch and we don't train them to use it differently, they're not going to get full advantage of that. Back to the myofunctional therapist, back to the breathing coaches that you can all become in your practices with not a lot of extra training, not a lot of extra time on your schedule, but tons of extra kudos from your better breathing patients. So the most important thing is that the nose is for breathing. There's no other part of our body that's for breathing. And the mouth is for other stuff. And they shouldn't, and what's the phrase? You should breathe through your mouth as often as you eat through your nose. Because it's really that plain. It's that important. So what do you do? What do you do in your practice to make this work? Ask about all the good medical history questions you have. Ask about all, ask about all the good dental history questions. They came to your office probably for oral health. If they're new to your practice and they don't know much about you, they may think that you're about the teeth and the gums and the jaw joints. And we have to be about the teeth, the gums and the jaw joints because we're the only part of medicine that is. But just like our other colleagues, we have to expand our thinking. We have to look up. We have to think about nasal function. We have to think about anatomy, physiology, and put all those things together. So to be able to do that, we have to ask questions to get the conversation started. We have to ask them about how comfortable they are. How well do you breathe through your nose? What's everybody going to say? They're going to say, fine. Why? Because they're used to the amount of work it takes to breathe through their nose. Their body is calibrated for the nose that they have. We're going to give them a different nose, maybe. We're going to make it clearer, easier to breathe, less resistive, more of a habit. And we're going to ask them later, how do you breathe through your nose? They're going to say, fine, because their body recalibrates. So just asking people about that, not good enough. We have to test them a little bit. Give them a nose score. Give them a 2-minute breathing through their nose function. Take their bolt timing. Find out how they respond. We can use the tools that we have. You can get fancy tools. You don't need them. They're great, but you don't need them. All you need is a mirror in a refrigerator. That works pretty well. I like that little test. It's fun. And we have to develop those relationships in our towns. Because again, we can't do this by ourselves. We have to do this in collaboration with others. Sometimes they require medications for their acute allergies. But just after the acute phase is done, we got to be questioning how they got that way. What's wrong with their current anatomy, their current physiology, their current habits, to where we can set them on a better pathway for long-term health by making sure they breathe 24/7 through their nose and only through their nose. So, there it is. There's my email address, seattlesleeped@gmail.com. I love to answer questions. I don't look at that email address all the time, But feel free to reach out with any questions. We're going to have a Q&A section at the end of the day today, right? 5 o'clock, right? And so I'll be happy to answer your questions then. Thank you.